Thank you very much for inviting me to speak today. These are my affiliations. It is an honor to be addressing you all today, both from the perspective of someone who feels very strongly about my patients having a voice, being able to express their side of things, because very much agree with the previous speaker, patients are not patients. They are people with a few symptoms and a particular illness. So for the purposes of this talk being a medical conference, when I refer to quality of life, just for ease, I will be referring to health-related quality of life. And I will refer to a couple of fairly early definitions. So the World Health Organization, as early as 1947, defined quality of life as a state of complete physical, mental, and social well-being, and not merely the absence of disease and infirmity. And I liked, so Karnofsky back in the 40s as well, when he was evaluating the impact of nitrogen mustards on advanced lung cancer, was also really quite progressive in acknowledging this concept of quality of life. So while he was evaluating nitrogen mustards, he felt that whilst evaluating these agents in cancer patients, it should also include not only performance status, length of remission, prolongation of life, but the patient's subjective improvement in terms of mood, attitude, general feelings of well-being, activity, appetite, and the alleviation of distressing symptoms. And I think he had such a good point when it came to some really toxic treatments that we do sometimes subject our patients to. So one of the things that struck me is that, quite often when we say treatment, people think drugs, medications, therapies. Well, no. One of the things that I deal with a lot are a group of patients with myelodysplastic syndromes, and I have two very different groups of myelodysplastic syndrome patients. I've got the transplant population, and then I've got the older, perhaps frailer, not always, individuals, and especially in the very early stages of diseases when they don't really have significant cytopenias or low blood counts, they get treated with watchful waiting. So having paradoxically been diagnosed with a disorder that could potentially be life-limiting in terms of their life expectancy overall, here they are. Watchful waiting, we'll see you in 3 months. So there are lots of non-curative therapeutic approaches: supportive transfusions, antibiotics, erythropoietin, hydroxycarbamide for cytoreductive therapy in patients with chronic myelomonocytic leukemia, for example, non-intensive chemotherapy or chemotherapy with non-curative intent. And then there's after treatment, and again, I emphasize there are a group of patients who may never actually get an after their diagnosis. The diagnosis is done with and resolved. So there are plenty of services and resources available, and I start with hospital and specialty-based services. Hematology and other doctors, clinical nurse specialists, and all nurses, including the palliative care team, transplant coordinators, clinical psychologists. The list goes on. And then in the community, the general practitioners, community physicians, district and community nurses, counseling, psychological input and support. And then just because I don't think that that's the most important and the be-all of treatment and support to be had for patients, this study was very interesting for me. Van Dulman published this, and in his introduction says, in the past decades, medical care has gradually and rightly shifted its emphasis from the disease to the patient, and a meeting between a patient and a doctor is a meeting between two very different extremes. Patient and doctor may have different roles, languages, expectations, and perspectives. So this particular study wanted to examine in what respect the communication between doctor and patient could be considered balanced in terms of the doctor's agenda versus the patient's agenda. And regardless of the nature of the clinical setting, whether it was internal medicine, pediatrics, or gynae in this particular study, they were very, very, very different. Patients were very focused on their psychosocial issues and how the disease affected them, and the doctors were more interested in the disease. So actually, considerably more important to a lot of patients in a lot of different time points through the course of their illness are the other services and resources available, patient groups and charities. General Cancer Support, Macmillan, Winston's Wish, which is an amazing charity which actually helps individuals tell their children how their disease is or the fact that they might die from their disease. Amazing charity. And then there are charities specific to hematological disorders, Bloodwise, Leukemia Care Anthony Nolan, disease-specific groups, and we have one of the chairs of a group that I work with quite closely here in the audience. And there are other local support groups and charities, usually close to the hospital and clinic settings. And I just put up the MDS UK Patient Support Group webpage because it is an amazing resource and it's very well laid out and very helpful for a lot of even my patients. I do direct them regularly to the website and written information produced by MDS UK. The written information from these charities is very important. This is a picture of a booklet produced by Bloodwise about watch and wait, or watchful waiting, which is very nicely laid out. And interestingly, there is acknowledgement. This is specifically for patients with CLL, but there is acknowledgement that individuals on a watchful waiting policy actually do report feeling really quite distressed about being told a diagnosis, given a load of booklets and waved off for a month, 2 months, 3 months, maybe longer. There is a significant lack of formal, methodical information giving from the hospital setting, but it is out there, and the individuals do need signposting to all of this. The MPN Landmark Survey was, for me, quite an interesting survey. This was conducted in the US in individuals with myelofibrosis, polycythemia, or essential thrombocytosis. It was a web-based survey tool, and patient data was collected over a period of a few months in 2014. The survey was only conducted in English, took about 22 minutes to complete, and 813 patients completed the survey. Reasonably even-ish split between the three groups. However, if you think about the sample size, given that this was what they described as a landmark survey for a very large group of individuals, polycythemia, 380 patients, and there are about 100,000 sufferers in the US. And in terms of the publications, one of the things that they published on was a patient-physician agreement on the reporting of symptoms. And by and large, there was agreement in some regards, but there were also some gaps. For example, difficulty sleeping, and the ET patients, about half experienced numbness and tingling, and only 14% of physicians acknowledged this being a top 5 symptom. And sources of disease information, I don't know whether there may have been a little bit of a bias in the population, as I possibly alluded to at the beginning, in that this was a web-based survey and the majority of individuals in this particular cohort of responders did turn to the internet primarily for their information source. In the UK, however, we've got the National Cancer Patient Experience Survey, which is it's been taken annually since 2010. It's been commissioned by the government for all, majority of healthcare in the UK is still NHS rather than private healthcare system. And this is designed to monitor the progress on cancer care in the UK, drive local quality improvements, assist commissioners and the fund holders to decide on certain priorities year on year. And this is quite a remarkable survey in that the numbers involved, so adult patients only discharged from an NHS trust, nearly 120,000 patients identified from databases, mandatory databases nationally, with a cancer diagnosis, of whom just about 10,000 were eliminated from that group, some of whom had already passed away, for example, or moved house, and of whom 72,788 responded. This is an overall response rate of 2/3, and this is consistent over the last 8 years. And it's mixed mode methodology. You could do it online, you could do it via post, you could do it on a free phone helpline, and there's even a translation service, although the numbers of individuals accessing the services that way were actually quite small. 92.1% in the UK cohort opted to do it via post rather than the web. So I don't think any one way fits all, really. So how do we gather information from the patient's perspective? Well, we've got patient-reported outcomes and the tools to measure them, which are patient-reported outcome measures. And this specifically refers to self-reporting by the patient. Gathering patient rather than clinical or other outcome perspectives. So it's not interpreted by a person delivering the questionnaire via telephone, for example, in any way. It's just as is. And there are a legion of different outcome measurement tools. And what I've always found very interesting is they've never necessarily been compared against each other. So in terms of choice of questionnaire in a study, in your clinic, pick the one that seems to be, one, accessible, two, easy to fill in. But beyond that, it's not always that straightforward. And the patient-reported outcome measures, as our previous speaker alluded to, is very multifaceted. So I'll run by this slide very quickly as we've gone through that already. And there are various routes of collection. I've already shown you some very different survey methodology between just the UK and the US, both primarily English-speaking countries, where a web-based online survey was undertaken in one country and primarily a postal survey in the other, with very different response rates. But questionnaires can be self-completed on paper. There are PDA smartphones, tablets, and for EQ5DY, for example, it can even be filled in by a carer or a proxy or a parent. And patient interviews as well, although I do emphasize it must not be interpreted by the individual delivering or giving out the questionnaire at all. So there are lots of different ways of measuring these, the Likert scale, visual analog scale, and again, whatever works. So I'd like to talk a little bit now about survivorship. So we've talked about individuals with various different diagnoses at various different time points and the various different types of quality measurement tools there are out there. And in terms of survivorship, this is the after-treatment side of things for the individuals who are fortunate enough to have had treatment and seen a resolution to their diagnosis, their lymphomas, their leukemias. And its underpinning recommendation within this particular survivorship document, again commissioned by the Department of Health in England, was to promote a cultural shift in professionals towards shared decision-making and supporting patient self-management. So the National Cancer Survivorship Initiative in the UK first launched in 2007, where initially there was a lot of focus in actually improving the cancer services in terms of diagnosis and treatment and early diagnosis, raising awareness of cancer symptoms or potential cancer symptoms, but also to develop the services to support and enable cancer survivors to live as healthy and as good a quality of life for as long as possible. And this initiative does recommend using patient-reported outcome measures to collect patient symptoms, concerns, and quality of life routinely from diagnosis onwards to help focus on what really matters to patients. We're very lucky in Sheffield that this culture was adopted reasonably early. So what we're trying to do is give lots of information and support from the point of diagnosis, promote recovery, sustain recovery, manage the consequences of treatment, and support people with active and advanced disease, as well as improving collectively survivorship intelligence. In Sheffield, we've got something called a late effects clinic. It's a formalized process. Individuals get referred to it at a time point where their disease is felt to be less dominant of an issue or a non-issue because they've achieved a cure or remission status. And this is run by a nurse consultant with vast experience in survivorship issues. This is the SPARK questionnaire, which is developed in-house in Sheffield and validated. It doesn't project terribly well, but the main categories are communication, information issues, physical, psychological symptoms, religious and spiritual issues, independence, activity, family, social issues, treatment issues, and personal issues. And that is given to individuals before they come into their first consultation with this individual, who's told me repeatedly that her most powerful tool during that clinic is the box of tissues that sits on the table, because people do often have quite a lot to talk about. So I think my take-home points for quality of life is not seeing the patient and calling them a patient, seeing them as a person who happens to have some health problems. It's really important to enable and empower patients, involve them in decision-making and discussions. Knowledge is power. Give them as much knowledge as they can deal with. And don't make assumptions about how much they can deal with. They're amazing. Survivorship should really start very, very early, even while they're on treatment. And bringing in patient-reported outcomes into routine clinical practice, I think, is a work in progress. Hopefully you'll stick around for my talk later this morning. But what we would like to do is bring in patient-reported outcomes into routine clinical practice everywhere. And to do so, I think we're going to have to simplify and speed up the process of self-reporting. And I would definitely emphasize that clinicians such as myself are not usually the most important person in the team. For example, I very much hope that most patients wake up in the morning and the thing they first think about are their families, not their doctor. With that, I thank you very much for your attention.